And then next is Lindsay. Dr. Caverly was volunteered this year, very cheerfully volunteered to be a speaker for us today. So she will be coming to talk about fighting back inflammation and infection. Good.
Thanks for the introduction. I'm happy to be here tonight. Thank you all for coming. And as Dr. Nasser said, my talk is titled Fighting Back Inflammation and Infection. So I'm going to talk in three different parts. I'm going to talk first about inflammation and infection in CF, the why, what, and the how. So why are we interested in inflammation and infection? What are the different types of bacteria that cause infections in people with CF? And then how do people with CF get these infections? Then I'll move to an overview of some of the current approaches that we have to fighting back against these things. So current treatments, and then also current strategies that we have to prevent infection from happening. And then finally, I'll talk about in the near future, what are the tools that we're going to have available for fighting inflammation and infection, including some of the new treatments being studied, and there's going to be some overlap with the slide that Dr. Nasser just showed about the treatments that are being under investigation, and I'll highlight some of the studies that we have going on in our center right now, specifically towards inflammation and infection. And then I'll talk a little bit at the end about how the new CFTR modulators are potentially going to act in our fighting back against inflammation and infection. So we'll start with the first part, the why, what, and how. And inflammation and infection are important in CF, one, because they've been there since the very first description. This is a picture of Dorothy Anderson, and she published the first description of people with CF back in 1938. And in this description, she identified infection in the lungs of these kids that she had identified as having something that she called cystic fibrosis of the pancreas, but we now know as CF. And the infection in these kids in their lungs were many of the same bacteria that we have in younger kids and babies with CF today, including Staph aureus and Haemophilus. So inflammation and infection are present in people with CF as early as infancy. We know that even in babies, there's inflammation that's more than babies without CF, and that infection starts early. And it's really important because the inflammation and infection are really closely related to lung disease progression. So the cycle of CF lung disease is a cycle of infection and inflammation that leads to airways obstruction, which is what eventually contributes to lung function decline over time. And fighting inflammation and infection has really played an important role, along with a lot of other aspects of CF care, but has played a big role in the improvements in survival and the stopping the decline in lung function over time. So targeting these things is really important to prevent lung disease. So what are the types of CF lung infections that we're talking about? Well, we know from the CF Foundation's Patient Registry Annual Data Report that infections in people with CF has been tracked for quite some time. So when people come to clinic and they get a sample, either a sputum sample or a throat swab, that sample is sent to the clinical microbiology lab, and that sample is put onto different bacterial plates for culture to identify the bacteria that are in the sample. And from these data, we've tracked the rates of infection in people with CF, the different types of infection, and how these rates vary across the age span. So we know that in early childhood, the most common infections include bacteria such as Staph aureus and Haemophilus influenza. And then as people get older kids, teenagers, and adults, the infections that become the most common include some of these bacteria you might hear people talking about. So Pseudomonas aeruginosa, Burkholderia cepacia complex, MRSA or methicillin-resistant Staph aureus, Stenotrophomonas multifilia, Achromobacter, and then the nontuberculous mycobacteria or NTM. So we know what these things are. We know how often they happen in people CF, and we know that these are some of the bacteria that are important in terms of targeting our treatments towards. And we also know that the rates of these infections have changed over time, and we've seen a lot of improvements with our current tools to fight these things over time. So this was a study recently that looked at bronchoscopy samples, so going in and taking a sample from the lower airways in a group of kids, babies and young children up to age 6, and this was done in Australia. And it looked at the rates of these infections with the bacteria that I just mentioned on the prior slide over time and how these have changed. And the primary finding here was that rates of two of the most prevalent infections in young kids with CF, Staph aureus and Pseudomonas, really had big decreases in their rates of infection over the past 20 years. So what we're using to fight these infections is working. The infection treatment and also infection prevention strategies is resulting in a decrease in these rates of infection over time. So the next question is, well, how do people with CF get these lung infections? And there's a couple different ways that this happens. So one, it can be through contact, so either direct contact by touching someone who has the infection or touching an infected surface, or indirect contact, touching an infected surface even after the fact of someone who had touched it initially. These can be transmitted through the air, so either direct, having a direct cough aerosol of someone that transmits directly to you, or indirect, some bacteria, after someone coughs, some bacteria can hang around in the air for a while, and you can have indirect transmission of the infections through that. And we also know that people with CF can be infected from other people with CF. And in particular, this has been shown to happen with bacteria such as Pseudomonas, Burkholderia, and potentially some of the NTM as well. And when these bacteria go to people with CF, the nature of the lungs in people with CF sets up an environment where they tend to stick around. So airways are inflamed, there's thick mucus, and bacteria, when people are exposed to them, can get caught in these airways and can get trapped and have a chronic infection come from there. So the next thing I'm going to talk about are some of the current approaches to infection and inflammation in CF. So our treatments and prevention, or you can think of them as the tools we have in our tool belt towards fighting infection, or our armor against infection, or the weapons that we're using to fight. And I'm going to review just a couple of the common ones and talk about how they work towards fighting infection and inflammation. So the first is Dornase alpha, and this is familiar to a lot of you, I'm sure. This is a nebulized medication. And the way that Dornase alpha works is that it cuts up the DNA in sputum. So the picture here, up here, is what CF sputum can look like. There's a lot of neutrophils, or those big purple circles, and those are a type of inflammatory cells that are really increased in the lungs of people with CF. And there's a lot of DNA from bacteria that has been killed and from the inflammatory cells themselves also. And so the Dornase alpha works to like scissors. It chops up that DNA and makes the mucus thinner, and really is very helpful in thinning the mucus and then making airway clearance easier and more effective. Azithromycin is another thing that we can use to fight inflammation. Azithromycin is an antibiotic, and in other circumstances it can be used as a 5-day course or a Z-Pack to treat an infection in the airways. But in people with CF, it's an antibiotic that can be taken 3 times per week and can be taken chronically. And taken this way in people with CF, it can really be helpful in fighting inflammation in certain people with CF, mostly people that have Pseudomonas infection, but sometimes people with other bacteria in their lungs can be helped by azithromycin as well. Inhaled steroids are another medication that can be used for inflammation in CF. This is an inhaled medication, either with a nebulizer or with an inhaler. And it's usually given either once or twice daily. And this is particularly helpful in people who have CF and asthma in helping control the inflammation in the lungs. The next tool in our tool belt for fighting infection is antibiotics. And antibiotics can be used daily treatments, so these can be daily suppressive medications, things that are taken every day to kind of keep those levels of bacteria lower and to help overall with the infection. And these can be either inhaled antibiotics, or less commonly, sometimes people are on antibiotics on a regular basis by mouth. And then on top of the daily treatments, there can be intermittent episodes of antibiotic treatment for an exacerbation or a flare-up in lung disease that are treated with antibiotics either by mouth, if it's something that you can manage at home, or intravenously if you're admitted to the hospital. Just as important as treating infection and inflammation is preventing infection. And so these are the infection control guidelines, and Dr. Nasser mentioned this a little bit also. And the infection control guidelines have a couple of different areas that they cover in terms of how do we prevent infection. And the first area of this is in everyday activity. So what can people with CF do and their families do to help prevent infection from setting in? The 6-foot rule we've talked about a little bit, and again, this is the movie 5 Feet Apart is a play on this. They're taking the 6-foot rule and they're reducing it to say they're going to be closer than this, but the guidelines are 6 feet apart from other people with CF, avoiding events with other people with CF, and then disinfection of your nebulizers, other devices for airway clearance, and keeping those clean per the guidelines. Things that are important in preventing infection in people without CF are even more important with CF. So cleaning your hands, covering your cough, and then getting vaccinated for influenza and for the regular childhood vaccines and so forth. And then in addition to everyday activities, the infection control guidelines cover what can people with CF do in the clinics and in the hospitals to try to avoid infection. And this includes things like wearing a surgical mask in all common areas of the hospitals and the clinics. Healthcare providers are partnering with people with CF in this too, so wearing the gown and gloves, disinfecting stethoscopes between patients, and then we're also cleaning the clinic rooms quite thoroughly between patients to avoid infection transmission. There's also some work going on behind the scenes in terms of monitoring for spread of infection between people with CF. And this happens in a couple different ways. So there's a couple different laboratories across the country that are looking at the bacteria that are coming from people with CF's respiratory cultures and looking at the different types of bacteria and making sure they're not catching evidence of outbreaks or transmission between patients. So this is happening at the University of Michigan. We have the Burkholderia lab led by Dr. LaPuma. And so he receives Burkholderia isolates from patients all over the country at different CF centers and is looking to make sure that there isn't evidence of outbreaks of Burkholderia, and that happens here on campus. There's a similar lab for the NTM, or the nontuberculous mycobacteria, and this is happening at National Jewish Health in Denver, Colorado, and they're looking similarly to make sure that there isn't transmission of NTM between patients. So what's coming down the pipeline? What are the new treatments being studied? And how about CFTR modulators? So this is a graph that's similar to the one that Dr. Nasser showed in terms of the studies that are currently going on through the CF Foundation, and this is specifically a blow-up of the drug development pipeline towards inflammation. And going through this, I'll highlight a couple that we're participating in with our center. So one, and I don't know if the words on the stripes project particularly well, but you can see sort of a broad overview of how many different studies are going on. And as Dr. Nasser mentioned, the different phases are the different phases that need to be marched through in terms of drug development before these drugs can be made available to the patients. So one that we're participating in is the Applaud study, and this is an oral drug, and it's a compound that is sort of a relative of vitamin A, but it can be useful to fight inflammation in the lungs of people with CF. In terms of fighting infection, here's a similar graph looking at how many drugs that we have under development for infection. The first part are the drugs that are currently available and include things like many of the inhaled antibiotics and azithromycin that I mentioned earlier. And then the list below are many of the therapies that are under development. Here's one that we're participating in, and it's a study of inhaled vancomycin for people with MRSA infection. And in addition to drug development, there's lots of other ways that we can work to improve how we fight infection and inflammation in people with CF. And I'll highlight a couple of the ones that we're participating in here again. And these are also clinical studies that are going on through the CF Foundation network. One is the STOP2 study, and this is addressing the question of what's the optimal length of IV antibiotic treatment for CF exacerbations. And so this will be looking at, based on how quickly someone's getting better during their exacerbation treatment, that person will be treated with either 10 or 14 days, or people that are responding more slowly will be treated with either 14 or 21 days. And hopefully from this study we'll get a lot of great data that'll really help tailor the length of treatment for CF exacerbations. Next, we're looking at how can we optimize combinations of antibiotics. So people are on a lot of antibiotics, but we saw the picture earlier from Dr. Nasser's presentation, and we know that a lot of these medications that people are on can potentially interact with each other, both for the good and sometimes for ways that we would rather them not, in terms of making each other less effective. So the TEACH study is looking at something like this, and this is looking at the effect of adding oral azithromycin to inhaled tobramycin. So it will help us work towards how can we really optimize combinations of antibiotics to really optimize our fighting of infection. We're also looking at how do we optimize antibiotic delivery. And this is the PIC study, and this is looking at people who come in and have a PIC line placed for their antibiotic administration and looking over time at rates of complications from PIC lines, such as infection or blood clots, and then down the road looking to see how can we prevent these in the future and better manage how we give people antibiotics. And then what about new infections? When someone has a culture in clinic that has a new result, how do we deal with that? Well, we have a couple studies that's looking at that aspect of infection too. One of them is the coupling of the patients and PREDICT studies, and these are studies looking at people with NTM infection, either Mycobacterium avium complex or abscessus complex, And this is an observational study looking at people with new infection. How do they do over time? How can we better use that information to better target treatment for NTM infection to the people that'll benefit most from it? And then also, what's the best treatment regimen, and how do we optimize that as well? Similarly, we have a study called STARTER, and this is instead of NTM, this is looking at MRSA infection. So when someone has a new MRSA infection, how can we use antibiotics to hopefully get rid of that infection before it sets in and becomes a chronic infection that may be harder to manage down the road? So the last section of the talk is on CFTR modulators, and Dr. Simon's going to speak about these quite a bit more in the next talk. But I wanted to touch particularly on the question of how are CFTR modulators going to affect lung infection and inflammation. A lot of this we don't quite know yet. They haven't been around long enough to have good long-term studies of how rates of infection are going to change with modulator use. The most data that we have has been with ivacaftor, because it's been around for the longest. And overall, things are really encouraging that modulators are going to be a great tool in our tool belt for a lot of reasons, but potentially because they help target infection and inflammation as well. And I'll show you just a couple pieces of data that support that. So here was one study that looked at ivacaftor in relation to inflammation. And this was a study of 12 people with CF, and it measured a lot of different inflammatory markers. So each of these 6 graphs here, is a different marker of inflammation from a sputum sample of someone with CF. And it compared these markers before and after starting ivacaftor treatment. And as you can see, based on the red line of all of these graphs, across the board, all 6 of these markers decreased while people were on ivacaftor treatment. So a decrease in sputum inflammation in multiple markers in the sputum. These happened within the first week of ivacaftor treatment, and it continued to decline over the whole 2 years of treatment. So really encouraging that the CFTR modulators are going to be acting on decreasing inflammation in the lungs as well. And then finally, I'll show you a little bit of data on ivacaftor and lung infection. This was a study of 20 adults with CF, and it looked at bacteria in the sputum before and after just 1 month of ivacaftor treatment. And in this study, multiple measures of infection improved after ivacaftor. So they measure the total amount of bacteria in the sputum, and there was a decrease in the total amount of bacteria in the sputum after just 1 month of ivacaftor. There's also a decrease in the total amount of Pseudomonas, looking at Pseudomonas by itself after ivacaftor. And then in a different study, there was a decrease also in overall rates of Pseudomonas infection when you looked at people that were treated with ivacaftor. So overall, also encouraging results that ivacaftor is going to alter the infection rates in the lungs, and also potentially alter the amount of infection and the types of bacteria that are going to be infecting the lungs. So there's a lot going on, and there's even a lot more to come. At the North American CF meeting this past fall, the CF Foundation announced that they're launching a new infection initiative, and they're going to be putting a new $100 million into specifically infection-related research. And exactly how that's going to happen hasn't quite yet been determined, but there's a number of different broad categories that they're hoping to put this money towards. And this includes improving detection and diagnosis. So right now we rely on throat swabs and sputum samples, and maybe there's different or better ways to do that. Maybe there's methods of using breath or non-invasive markers of infection that we could use to help diagnose things. That's definitely an area of interest. Better understanding the infections that people with CF have, developing new treatments, further improving the current treatments that we have to help optimize their efficacy, evaluating long-term antibiotic use, both for the good, how it can be helpful, and also maybe how we could alter it to further improve outcomes, and then looking overall at the future of CF infection. How is this going to look when people are all on good modulators, which is expected to happen in the near future? So in conclusion, inflammation and infection are important to recognize, treat, and prevent in CF. And we have many tools in our tool belt to fight inflammation and infection, and there's a lot more of these to come in the future. Thank you.